All right. Can Justina hear me okay now?
Yeah.
All right. How do you know?
She just told me.
Okay. All right. Okay, so my deltoid ligament is going to branch off into 4 different sections, okay? And the 4 different sections are all going to be named based on what they attach. So the first one I'm going to see here is something called the anterior tibio-talar. So if we draw in my little talus, this is going to be my anterior tibio-talar, right? Says what it is what it says. I know you've heard that 100,000 times before. Probably hear it in your sleep. Now, you also know if I have an anterior tibio-talar, I'm going to have a posterior tibio-talar, right? So before we add in any more ligaments, let's start to think about what motions the anterior tibio-talar and the posterior tibio-talar would prevent. Okay, so we know that they're going to prevent motion or excessive motion between my tibia and my talus. Cool, awesome. Both of these ligaments are positioned on the medial ankle, the medial side. Okay? So if they're positioned on the medial side, what motion at the talocrural joint, aka ankle joint, would stretch those ligaments? Eversion, right? So we know that both of them are going to prevent eversion. Now, the really nice thing about the anterior tibio-talar and the posterior tibio-talar is that if we took those 2 ligaments and we put them together, what group of ligaments at the knee does that look like? ACL, PCL, doesn't it? Right? So the really big advantage to that is that those ligaments are going to mimic what my ACL and PCL do at my knee. Right? Okay, so as review, my anterior cruciate ligament prevents what? Right. Excessive displacement, excessive anterior translation of my tibia. The anterior tibio-talar is going to prevent excessive anterior displacement of my talus. Right? Easy as pie. Says what it does what it says. Right? It's in the name. The posterior tibio-talar is going to do exactly what my PCL does. Right? It's going to prevent excessive posterior translation of my talus. That's pretty darn easy. The other 2 ligaments I'm going to encounter here are going to be something called the tibio-navicular and the tibio-calcaneal, or calcaneal, depending how you pronounce it. Remember, I pronounce things weird. I don't say malleolus, I say malleolus, so forgive me. So if we say this is my calcaneus down here, I'm going to have a tibial calcaneal or tibial calcaneal ligament. It's really random. So let's think about what my tibial calcaneal ligament would do. Okay, obviously it attaches my tibia to my calcaneus. So first question is pretty easy. Would my tibial calcaneal ligament have any effect on my talus? No, because it doesn't attach to my talus. It goes from my tibia to my calcaneus. It's not necessarily going to prevent excessive plantar flexion because it's in the posterior compartment. Okay? So would it potentially prevent excessive dorsiflexion? Yeah. Also, in addition to that, because it's in the medial side, it's also going to prevent eversion. Okay? So this is really where, and I hope you guys are getting a little bit more of an appreciation or picture of this. I need to ask that patient those follow-up questions. What I do a lot of times is I will say, show me the position your foot and ankle were in on the other side. And they will give you pretty much a pretty good recollection of what happened. Okay? So think about this. We got football player, soccer player, rugby player, volleyball player, doesn't matter. Fill in your favorite sport, not swimming. Right? It's not going to affect swimming or equestrian, unless you fall off a horse. Right? So here I have my patient. Okay, patient, how did you get hurt? Well, first question I need to ask him is where does it hurt, right? So if I have pain on the medial side, I should be thinking about medial side structures. Makes sense? We've already talked about the relationship between knee flexion and dorsiflexion, right? So when I flex my knee and my foot's planted on the ground, I'm going to have resultant dorsiflexion. Cool. So let's think about this. I plant, guy comes in, hits me from the lateral side. Okay? I could stretch my MCL. Much different story, because what position is my ankle in? Inversion or eversion? Is my ankle inversion or eversion? It's an inversion. Okay? Look at that ankle. Go aside. Okay? My foot's on the ground. My knee's caving in to valgus. My foot is in inversion. Now, much different story. I plant, guy comes in, hits me on the medial side. My knee buckles out. It's even hard for me to do. Foot's on the ground. I'm going to now be eversion. Okay? The way you can check that, or it's going to be a little bit inversion. Okay? Here, if I bring that foot up off the ground and send my knee, I'm an inversion. Okay? So inversion here, inversion here. See that? Okay? Eversion, open chain. It's hard for me to see, but hope you get it. Eversion, open, close chain. So think about that, all right? So I need my patient to pretty well mimic how they got hurt. I also need to find out all the extraneous forces, right? Was this a result of a jump? Was it a result of a bad landing? Did they step in a hole, right? I had a guy, he had an unholy triad, right? Because he was playing soccer in an adult league and stepped in a hole. So you have to go through, you kind of have to live that mechanism of injury with these patients. The fourth ligament we're going to have here is actually going to attach into the navicular. And this is going to be my tibial navicular ligament. It's not going to attach into my talus. It's going to attach into the navicular. Bless you. So we can already kind of get an appreciation for what this ligament's going to do. Right? This ligament is going to prevent the motion between my tibia and my navicular. Right? That's why it's called tibio-navicular ligaments. Where you may see an injury like this, or to this particular structure, it's going to prevent anterior displacement of the navicular on the tibia, right? Also is going to prevent posterior tibial displacement against the navicular. So here's where this one happens a lot. Somebody plants playing football, someone comes in from the front and tries to take out their ankles with their helmet or shoulder pads, and it forces their tibia posteriorly. Exactly. It just gets all pushed back. Because when I plant, I'm in a closed system. I'm in a closed chain, right? We can all agree on that. However, what I have to think about is if I'm planted on the ground, I'm in that closed chain, my foot is fixed, especially because what type of footwear are you going to wear if you're playing on grass? What are cleats designed to do? Make your foot stick in the ground, right? If I'm wearing baseball spikes, even worse, right? Baseball spikes really make you stick in the ground, depending on the surface, right? If you're dirt, not so much. Out in the field, a lot. But my foot's stuck in the ground, and now I had an external force pushing my tibia posteriorly. So I need to think about those things, all right? Any questions on the medial ankle? You say what again? So it's going to prevent anterior displacement of the navicular or posterior displacement of the tibia. Dorsiflexion and knee version. And same rules, right? Same. I mean, that's why I like drawing these things out. I understand they're absolutely terrible drawings. But if you can get an understanding of where all these ligaments are in their respective locations, you can use some problem-solving skills, and you can figure out what they're going to prevent. Okay? All right, any other questions on medial ankle ligaments? Yes?
Can you demonstrate the inversion, when you get lateral?
Eversion, inversion when you want to get hit lateral? Yeah, okay. I can't do the eversion very well. So I can't do it. All right, so I'll tell you, this is the best I've seen in about 2 years. I need to be all bruised up fighting. All right, open shade, you can agree on it. Inversion, cool, right? Eversion, cool. Close shade. Eversion, I'll try to get my foot on the ground. Inversion. Okay? And going in inversion there. But this is relative motion, right? So you guys in test and measure learn how to do everything open chain. Right? You place the patient supine, the muscle below, no, whatever. And you guys learn inversion, eversion. This is no different than when we did this for the hips. Okay, so remember the hips. Remember abduction, right? Abduction, no different. I'm just moving the different bone around the axis. Okay? So to your point, what happens a lot of times is player goes running down the field, either gets slide tackle, rugby, whatever, right? Whatever it is, they plant, put sperm on the ground, they take a lateral force that's directed medially. Okay, because we can all agree, if I get hit from the outside, that force line is towards the middle, towards center. That's a medially directed force. I'm going to do an inversion. Make sense? Okay. Any other questions on it? Okay, I want to make sure you guys understand. What's that? All right, so the lateral ankle. Lateral ankle is a little more, let's call it easier. It's a little easier, but it's also going to be more clinically relevant because we're going to see many, many more inversion sprains than we do eversion sprains. If I had to put a ratio on it, and this is just my experience, I probably see 4 inversion sprains to every eversion sprain. And that's just me. There might be some PT out there that sees equal. All right, so lateral ankle. So now, if I'm looking at my bones, that's going to be my fibula. That's going to be my calcaneus. That's going to be my talus. And my navicular. So I have 3 basic ligaments here. Okay, the first one that I have is going to be called the Anterior Talofibular. So my anterior talofibular attaches my fibula, aka my lateral malleolus, down to my talus. Okay, its position, it's located in the lateral compartment. It's also positioned, located a little bit in the anterior compartment. Okay, so what I want you to think about is I want you to think about what 2 motions that ligament would prevent. Inversion, that's the easy one. What else we got? Okay, so inversion. Maybe plantar flexion. Who's going for plantar flexion? Who's going for dorsiflexion? Who's going for hip abduction? Okay. So plantar flexion and inversion is what it's going to prevent. This is why we see so many anterior talofibular ligament injuries in the clinic, especially sports injuries. You'll hear this commonly referred to as the ATF or the ATFL, and that's simply just the abbreviation. But hopefully you guys can understand and guys appreciate the fact that this ligament is often ruptured in sports, especially like soccer, because of the position that the ankle is placed in during a lot of those injuries, right? This is most commonly going to be what patients refer to when they quote roll an ankle. And we can kind of think about that, right? So if I'm that patient and I accidentally step incorrectly, and I do not hit on the heads of my metatarsal bones, but I rather invert and hit on my fifth metatarsal, and my body weight is going forward and down, and my foot is planted, what happens? I invert, right? And I can plantar flex, right? Or what more commonly happens is this foot gets stuck, and I go into sometimes dorsiflexion, sometimes plantar flexion, if the inversion is enough. So if I'm way out here, and I invert a ton, with a ton of internal rotation, then I can also plantar flex. But what I'm thinking about is plantar flexion, inversion, especially inversion, is going to put that ATFL at a ton of risk. Okay? How do I do it? Like literally what happens is as you invert, I'm going to hold on so I don't actually do it. Body comes through and either lands or they land with an extended knee. And what they do is they try to take a step. And you can see it there. Yeah. So I'll do that again for you guys. Like I said, I'm going to hold on so I don't actually do it. I'll do that. Okay, so what happens is they invert, they hit the ton of inversion, come through, and that foot stays backwards. It doesn't come very much. As it is. Okay, so that's the position. So plantar flexion, inversion.
Now, like during that phase,
It can potentially fall into dorsiflexion, yes. So rarely does a patient have one injury. Okay, we're going to get into that next. Because, and I will tell you this from clinical experience and the literature and good evidence-based practice. Bonus question. What group of muscles are going to be at risk for tearing or developing some sort of awful tendinitis? By everters, right? Fibularis longus, fibularis brevis. So that's something that I would highly recommend, right? That should be part of your clinical practice anyway. If we're testing strength, it makes no sense to me just to test dorsiflexion and plantar flexion. But let's think about this, okay? My patient has swelling and pain around the lateral compartment of the ankle, because we all know these things, because there's a lot of open space on the lateral side, they swell up like nobody's business, right? Right, they're huge. My patient has a lot of swelling, discoloration on the lateral ankle. They have painful inversion, or in a super duper bad case, they have painless inversion, but a whole bunch of it, right? What's normal range for inversion? What's normal range for inversion? It's 40, 45, somewhere around there, 30 something, right? Okay, so if you measure your patient and they have 90 degrees of inversion, and that sounds ridiculous, and everyone's going, hold, I'm telling you right now, this guy's had it. I have had it. I have taken that ankle and I've gone, okay, here we go. And I'm thinking, this can stop anytime now. This is getting a little uncomfortable. And all of a sudden, their ankle cycles. Okay, so I would call that excessive inversion, right? Usually not. Yeah, but that's exactly my point, right? Because you guys are going to learn this next year in MSK. There's going to be grades of sprains, right? Grade 1, grade 2, grade 3. And there's a lot of times that if the entire structure is ruptured, the nerves are also ruptured too. And sometimes you will have a painless motion, but excessive motion. Sometimes if it's a muscle and it's completely torn, you will have a painless but super duper weak motion. Okay, so let's play on that a little bit. So my patient comes in, they have this discoloration, weekend warrior, fell in a soccer match, inversion sprain. Cool. They also have absent eversion. When you manual muscle test them, no eversion. Zippo. Why? What muscles control eversion? Fibularis longus, fibularis brevis. So what that means is that not only have they torn the ATFL, but they've also ruptured fibularis longus and fibularis brevis. Okay? And watch out for that, because like I said, rarely are you going to be dealing with just one thing. More often than not, there are several factors at play. All right. So like I said, we have an anterior talofibular ligament. We also, because this is anatomy, are going to have a posterior talofibular ligament. Now my posterior talofibular ligament is going to prevent what two motions? Inversion, dorsiflexion. It's also going to do anterior translation, you're right. But in terms of just cardinal motions, inversion and dorsiflexion. Okay, so much different scenario here, right? So I see plenty of posterior talofibular ligament injuries, but typically they have a little different mechanism of injury. I will tell you clinically, more often than not, patients just go ahead and tear them both, just to be nice. Makes job a little easier. All right, one more ligament here, and then we'll take a 5-minute break, okay? The other ligament I'm going to have here is going to be in the posterior compartment, and it's going to be the calcaneal fibular ligament. So the calcaneal fibular ligament is located exclusively in the posterior section. And if you look at it from kind of a back to front view, yes, it's kind of on the lateral ankle, but it's really super duper close to the midline. So if that ligament is in the lateral section, in the lateral compartment, but super duper close to the midline, what's going to be the number one motion it's going to prevent? Or dorsiflexion. Yeah, it's going to prevent dorsiflexion. And that's one thing that we're going to do after the break, is we're going to draw kind of, and I'm going to use the biomechanics term, we're going to draw an anatomy circle. I didn't hear a yay. Okay. What's that? I know. So we'll draw a little anatomy circle, and it should help with some of these combination motions, right? Because just like with anatomy circles, the closer that objects are, structures are to one of the cardinal axes or one of the cardinal planes, they pretty much do that motion exclusively, or pretty darn close to it. All right, it's 12:53. Let's come back at 12:59. Yeah.
Did you say posterior talofibular?
That's correct.
So ACM today, the top section.
Two in front to prevent two in the back. That's all. That's perfectly down.
Well, I was talking about.
It's rare. It's rare. It's tough. It's tough. And, I mean, like I said, rarely is somebody going to actually tear one. More often than not, they tear most of the deltoid ligaments. Or you have this weird, like, partially tore one and completely tore the other, or partially tore a couple. And, yeah, very much so. Very much so. Yeah. This is, yeah. There are, yeah, there's depending on what so this is but I take it really because what is the definition of torsion? Everything 1% to 99%. Right. So if we didn't, so this happened really early next year. So there says, hey, all I will say is, I have to go through this, but I very quickly do that. Wow. Like, I'm surprised that I'm walking correctly because he jammed his foot so far through that ball that I was walking in front of him. You were talking about gate after yeah. So here's the thing. Okay, now, what's that? The reality is, in circle, is not on interpretation. Well, the one part here, like, there were a couple fibers and you got like, therapist doesn't know any of this story. So the interpretation, this is what so now my therapist because I gave the patient just the therapist giving the patient so They're totally, really, so right now, I was the only one that his system. So we have a standing order However, let's think about it. You have the deltoid ligament.
Medial side. They have only
All right, guys, let's go and get rolling again. Okay, so I had a couple really interesting questions over break, and I want everybody to benefit from them. All right, so I got a question. If a ligament is completely ruptured, does the patient require surgery? Not always, right? I'm going to give you that PT school answer. You guys already know it. Say it in unison. It depends, right? Now, the code for it depends is I need more information on the patient. That's basically all it means. So let's think about this. I have a grade 3, it's gone, rupture of the ATFL in a 22-year-old D1 soccer player versus a 92-year-old grandmother who's getting surgery. Why not the 92-year-old? What's that? So there's one thing, right? So if I have advanced age, probably have some osteoporosis, something else going on, might be a hip fracture or something. Here's the other thing. For those of you who had surgery, or you put out during that surgery, is there a risk to putting somebody in advanced age under? Yes, there is.
Some people have like low risk, heal quicker, like recovery time.
Right.
Like that.
Risk versus benefit. Risk versus benefit. Exactly. Now, there are exceptions to the rule. The exception I'm going to bring up is Joe Paterno. Okay? So who knows what happened to Joe Paterno, and it was specifically his knee, not all the other stuff, right? But specifically to his knee, I won't hear about all the other stuff, right? He got, okay, so yeah, exactly. So Joe Paterno got hit on the sideline. Joe Paterno tore his ACL at 78 years old. Okay? Story goes, Joe Paterno was supposed to get a total knee because he's 78. Joe Paterno elected not to get the total knee. He elected to get his ACL repaired. Why? Okay, number one, he's a grown man, he can make his own decisions. But what can't I do after a total knee? Run. He wanted to run with the team on the field. So he got an ACL repair so he could continue to run on the field with the team, right? So my point is there's going to be a ton of exceptions. A ton of exceptions. All right, so any questions on lateral ankle, medial ankle, anything like that? All right. Okay, so the next thing I want to do, as promised, we're going to draw this little anatomy circle. I know everyone is excited for that. Yes. Can you say that louder, please? Not on the lateral side? No. There's a couple, there's a Tailor, there's anterior Tailor navicular that's right in the middle. But as far as lateral compartment, not so much. All right, here we go. Anatomy circle. So we're going to call that anterior, we're going to call that posterior, we're going to call that medial, and we're going to call that lateral. Okay, so we went over 7 ligaments, okay? Half of them are in the anterior compartment, half of them in the medial compartment, half of them in the lateral compartment. So if I'm in the medial compartment, what I need to think about is I'm going to have anterior tibio-talar, right? And if anterior tibio-talar is in the anterior compartment, then, my gosh, I'm going to have the posterior tibio-talar in the posterior compartment. Now, here's the other thing we need to think about. We need to think about not only the location of these, but like I said earlier, what each motion or motions these ligaments are going to prevent. So if I'm in the anterior compartment, I'm going to prevent plantar flexion, right? If I'm in the posterior compartment, I'm going to prevent dorsiflexion. If I'm in the medial compartment, I'm going to prevent eversion. And if I'm in the lateral compartment, I'm going to prevent inversion. So then depending on what quadrant these ligaments are in, that should tell you the 2 motions that they prevent, right? So this posterior tibio-talar is in, let's call it quadrant medial posterior. It's going to prevent dorsiflexion and eversion, right? If I'm in quadrant medial anterior, I'm going to prevent plantar flexion and eversion. My tibio navicular is going to sit over here as well. And then down here in the posterior compartment, tibial calcaneal. For the lateral compartment, it's pretty easy. Anterior talofibular is going to be in this lateral anterior compartment. Posterior talofibular is going to be in this lateral posterior compartment. And then the last one I'm going to draw in, I'm going to put a big asterisk with it because it's going to be really close to the midline, even though it's in the lateral posterior compartment, and that's going to be that calcaneal fibular ligaments. So what I want to do is just provide another different representation, a different graphic. Me personally, I look at something like this, especially in environments like exams. And what I see is I see a shortcut, right? So I can draw up the circle, and I can do this not only for the ligaments, but I also could do this for the muscles that control my foot and ankle too, right? All those muscles that cross that ankle joint are going to cross in one of these four components, or one of these four quadrants. So to me, anatomy circles are a really good way to provide a shortcut. Because if I do the circle, I can pretty much figure everything out. All right, so like I said, I just wanted to provide that for you guys as a different way of looking at all this. Yeah. That's my little 4 attempt at an asterisk. So let's do this. How about that? Is that better? Okay. What can I say? Artist, I am not. If you haven't figured that out yet, I was not an art major. All right, so the next thing I want to go over is going to be the arches of the foot. Now, the first thing I'm going to do, because I want to be consistent with grays, is we're going to cross out this one right there. So you will look at some literature, and it will say there are 4 arches to the foot. It'll say the medial longitudinal arch, the lateral longitudinal arch, and the transverse tarsal arch, and the transverse metatarsal arch. Understand that we do have 4 arches to the foot. Okay, we kind of talked about the ligaments that support those arches last time we were together. Just understand that when it comes to my medial longitudinal arch, that's going to be the arch that is most visible. When people talk about fallen arches, or high arches, or whatever, that's what they're typically referring to. That's the most visible arch, is that medial longitudinal arch. The transverse metatarsal arch can be visible. To be quite frank with you, typically we have quite a bit of callus and skin buildup on the plantar surface of the metatarsal heads. Yes, I do. And it's not the easiest to see. Okay? So I just want to go over, if you see in the literature, I think Oatis and Grays are inconsistent. I think Oatis has 4 arches, and I think Grays has 3. We're going to go with Grays. Okay, so that way we're just consistent with Grays. Okay, so 3 arches is what we're going to be dealing with here. All right. So finally, without any further ado, not the plantar fascia. We are finally going to start covering muscle. It's only been, what, 4 lectures in? We're finally going to cover the first muscle of the foot. So in terms of musculature, in terms of myology, the anterior side, the dorsal side is super duper easy. There's only 2 muscles. The plantar surface is what gets a little more confusing because we're going to have 4 layers of muscle on the plantar surface. Now, what I will tell you is that they're not that difficult. Okay, we're going to group them out and we're going to get through them. Okay, so on the anterior or dorsal side, extensor digitorum brevis is going to be the big one. Now, this one goes by a little nickname of the puffball muscle. And the reason it's called the puffball muscle is that if you perform its actions, which are going to be dorsiflexion, obviously, and especially extension of the lateral 5 toes, toes 2 through 5, what happens? You guys can probably reach down and feel it. You feel this little muscle puff out, this little muscle pop out. So that's the little puffball that you see when you have that patient perform dorsiflexion and toe extension. Now, what extensor digitorum brevis is going to do is, and regraze, it comes off of like the superior lateral surface of the calcaneus, and goes down to the sides of the tendons of extensor digitorum longus, right? So extensor digitorum brevis, we're going to call that EDB, is going to insert into the tendons of EDL. Now, we encountered this before. We encountered this actually last semester. And I'm going to bring back a really horrible, nasty term that everybody probably doesn't like. So in our feet, we have an extensor hood mechanism. It looks exactly like the one in the hand, with one huge distinct difference. It's a whole heck of a lot smaller in the foot than it is the hand. It's a super duper tiny little thing. In fact, if you get it dissected, more power to you. The advantage of having the extensor hood mechanism in the foot is almost exactly the advantage to having it in the hand. So what we're going to see is I'm still going to have lumbricals. My foot has lumbricals. My foot has extensor digitorum longus, flexor digitorum longus, the brevis components of those as well, or brevis partners. And I'm going to see that I can extend my toes, and I can extend certain parts of my toes if I'm coordinated enough, right? I mean, most people are not that coordinated with their feet. Some people are. But it's all going to go through that extensor hood mechanism. The other muscle that I'm going to encounter here is going to be extensor hallucis brevis, okay? Or what's commonly referred to as the HB. Now, again, extensor hallucis brevis says what it does what it says, right? It's going to do the exact same thing as extensor hallucis longus. In fact, if you look at the origin, it's going to have the exact same origin as extensor digitorum brevis, right? It's going to come off that superlateral calcaneus. The only difference is extensor hallucis brevis goes to the great toe, right? Extensor digitorum brevis goes to the other toes. That's really and truly the only difference. Now, with both of these muscles, we are going to see that they're innervated by the deep fibular nerve. Right? And mostly coming off of nerve roots S1 and S2. Same thing with extensor hallucis brevis. this is a big reason why we need to be very thorough with our evaluations, okay? Let's think about it. Okay, where do S1 and S2 originate? Sacral levels 1 and 2, my spinal cord, right? So is it entirely possible that my patient is going to have difficulty extending their great toe if they have an S1 or S2 nerve root impingement, rupture, whatever? Heck yeah, it is. It is. But here's the problem. My patient's going to come in with what diagnosis? Foot pain, foot weakness, foot drop, you name it. Okay? And if I only look at their foot, will I give them the appropriate treatment? No. Now, are they going to need some ankle exercise, a little bit of TheraBand, all that great stuff? Probably. But I need to get at the root of the problem, no pun intended. Okay, so those are going to be the two big muscles off of the anterior or dorsal surface of the foot. Like I said, those are the easy ones. Now, coming off of the plantar surface of the foot, that's where life gets a little more interesting. So first thing we're going to do is we're going to draw out the bones of the foot. We haven't done that yet. This is now a really good time to do it. This is going to be a bottom-up view, if you will. This is kind of an exploded view. This person had a problem with their feet. All right, so layer one, I'll give everyone a second to draw out the rest of the foot here. Layer one's pretty easy. So layer one, abductor hallucis, flexor digitorum brevis, abductor digiti minimi. We're going to start superficial and go deep. Good question. So this is so layer 1 is the most superficial layer. This is going to become really super duper important because, I don't know, Dr. Justice, what do you think? Should we peel back a couple layers and tag something for a lab exam?
Sure will.
So you might have to count how many layers are peeled back.
Some people have already found that those layers are very compressed, and so there's lots of confusion between those layers.
Oh, yeah.
I'm trying to get into that.
Oh, yeah, absolutely. Absolutely. Okay, so abductor digiti minimi says what it does, and it does what it says. Okay, it's going to come off of like the lateral process of the calcaneal tuberosity and all this great stuff off the lateral calcaneus. And then it attaches in to essentially the 5th digit. It should make a lot of sense. So that's abductor digiti minimi. Flexor digitorum brevis is going to come off of essentially the calcaneus and a little bit of the plantar aponeurosis. And it's going to do what it says and says what it does, right? It's going to flex my little digits. My abductor hallucis, again, is going to come off of essentially the calcaneus, and it's going to come out to my great toe. I'm just going to draw an arrow to that. No sense in writing it out again. And my abductor hallucis is going to abduct my hallucis. So the big thing I need to understand here as well, and this will get into a little bit of the nerve innervation, a little bit of the nerve supply, obviously the bottom of the foot, is that a lot of these muscles are going to be innervated by 1 or 2 nerves, or 1 of 2 nerves, I should say. We really only have 2 main options here: medial plantar nerve and lateral plantar nerve. Now, this is what makes it a little more difficult. The medial plantar nerve and the lateral plantar nerve are both branches off of the tibial nerve. And that is a distinct difference between the foot and the hand. Well, remember what we saw in the hand? Median nerve did a whole bunch, ulnar nerve did the rest. But they came off 2 distinct, totally distinct branches off the brachial plexus. Now we don't have that. Now what we have is we have a lateral plantar nerve and a medial plantar nerve that are both branches off the same nerve. That is a big reason why we have much more dexterity on individual fingers in our hands than we do our feet. Now, there's some people out there that they can, play the piano with their toes or whatever. But, and there are, right? And they have trained themselves to do that. But as it stands, my tibial nerve is going to branch into the medial plantar nerve and the lateral plantar nerve. My more lateral structures are going to get the lateral plantar nerve. More medial structures are going to get the medial plantar nerve. Right? Nice and easy. Yeah.
The red that's at 1, 2, 3, 4, 5, that's indicating that that's part of metatarsals. That's not
Yep, those are all metatarsal. I just didn't want to do it in black. I'll make another poor attempt at an asterisk.
Both conditions, same root levels.
essentially, it's S1, 2, and 3. Depending on what muscle they innervate, the muscle will get either S1 and S2 or S1, 2, and 3. Just like with sciatic, just like with all the rest of it, right? The lower the structure, the lower the root levels. That's typically how it works. But good question, good question. All right, so layer 1, abductor hallucis, flexor digitorum brevis, abductor digiti minimi. How I remembered this when I was in PT school, way back when, was layer 1 was AFA. Okay, that's how I remember it, was AFA. And I saw the commonalities between those. They all come off the calcaneus. I got 2 abductors and I got a flexor. And that's it. That's it for layer 1. Okay, any questions on layer 1? All right. We're going to redraw the foot again. And we're going to go on to layer 2. Layer 2 is even easier. Okay, so layer 2 is only going to have 2 different muscles, okay, and they are 2 super duper great important muscles. The first one is going to be called Quadratus Plantae. And the second one, I will say, is going to be an oldie but a goodie. All right, we can't get away from those lumbricals. Now, the good news is that my lumbricals are going to have the exact same action in the foot that they did the hand. They're going to have the exact same sort of attachment. Okay, so you remember in the hand, and I know that's like way last year, but in the hand, remember that my lumbricals didn't have any sort of bony attachment, did they? They attached in the tendon and the extensor hood. Same thing's going to happen here. Okay, so my lumbricals are going to attach in, they're going to originate from my flexor digitorum longus tendon. So that's exactly what we see, is that I'm going to have flexor digitorum longus, and I'm going to draw it in black here. So I have flexor digitorum longus, and then I'm going to have these little lumbricals that come off of them. And these little lumbricals are going to insert into that extensor hood. And they're going to have the exact same action that we saw in the hand. Remember, MP flexion, PIP extension. You guys remember that from last semester, right? That whole number. So my lumbricals in my foot are going to flex my MTPJ, metatarsal phalangeal joints. And they're going to extend the proximal interphalangeal joint of my toes. Like I said, these are extremely underdeveloped muscles in the foot. Honestly, a lot of it is a remnant from evolution. We don't use them much anymore, especially since we started wearing shoes and walking on concrete, but they're there. Now, the other muscle we're going to encounter here in the second layer is going to be this Quadratus Plantae. Quadratus Plantae is the square muscle of the foot. This is another muscle that's going to attach in to the FDL tendon, the flexor digitorum longus tendon. It's going to come off of the calcaneus, but then it just kind of lives down here and attaches right into that FDL tendon. Now, what I will say, the Quadratus Plantae is really, really super important because the Quadratus Plantae, let's think about what it does. If it attaches in to the flexor digitorum longus tendons, what would you suspect that that muscle would do? What's the action of that muscle? It's going to help, it's going to pull on, it's going to assist flexor digitorum longus, is it not? Right? Now, that is a really good key piece of information, a really good reason why maybe my patient will have some plantar pain. Because let's think about this, and this will be the last point we make for the day. On the plantar surface of my foot, all I see from flexor digitorum longus is tendon, right? Where's the muscle belly of flexor digitorum longus? It's way up on my proximal tibia, mostly fibula, isn't it? So how long is that muscle belly for flexor digitorum longus? About like that on average. What's the entire rest of the structure? It's all tendon. Tendon is contractile or non-contractile? It is non-contractile. So think about that. I have, and we saw this in the forearm too, really super duper short muscle belly, really super duper long tendon that has to move a lot of different joints. The one big advantage that the foot has is that Quadratus Plantae will help assist by pulling that flexor digitorum longus tendon posteriorly towards the calcaneus, thus providing a little bit more of a mechanical advantage to that muscle. Okay? All right, so that's 2 layers down. Let's go ahead and cut it there. And then, like I said, I'm not going to be here on Wednesday. I'll be here next Monday, and we'll finish up plantar surface and all the muscles. Yep, you guys are having a lecture on Wednesday. Dr. Justice is doing a lecture that day. Did I hear a woo-woo? Who gave that a woo?